Hi friends, I am Dr. Sajid Ansari, cardiologist from Lucknow. Welcome to all of you. Just I am going to discuss few words about heart failures and what is the myths right nowadays while managing the heart failure. Friends, in spite of all treatment, heart failure mortality was still high and still it is high, not only it was high. So, there was tremendous improvement in treatment of heart failure starting from the ARNI to SGLT2 inhibitor, and they really brings up reducing the mortality rate by using this kind of molecule. The issue with heart failure was that when we say that I am treating the heart failure, not per se just think of HFrEF, heart failure with a reduced ejection fraction, where we stand for with mid-range ejection fraction, and what about HFpEF with a preserved ejection fraction. Usually at physician level they looks like ejection fraction is looking normal, but they are not looking to pinpoint the filling pressure where the PCWP is the very high, L index volume is high, there is some target organ damage like concentric hypertrophy of left ventricle. So, these things should be see on the same time, and we know that echocardiography is a very important tool, decision making, just to putting probe on the precardium and see what the ejection fraction, how is LA behaving, and see the transmittal flow velocity and tissue Doppler velocity, and just to calculate the filling pressure, and this way you are able to find out the what the filling pressure. So, coming to era of SGLT2 and ARNI, then there is now consensus after using all the guideline directed medical therapy, either ASARB, beta blocker, MRA, whatever you are using, the what is the next? Next is either SGLT2 or ARNI, and we know that there is a lot of trial in the domain. I am big fan of ARNI because we know the paradigm of trial. It was published, although this was in the chronic stable heart failure, and there is roughly rate of 20. There are 20% reduction around in the primary and secondary endpoint and some explorative endpoint also. And here I would like to put one thing, that the active comparator for ARNI was ACE inhibitor enalapril, that has already reduced mortality around 14% by SOLVE trial. So, coming to era of SGLT2, after the publication of DAPA-HF trial and DAPA-PRESERVE and even the impart-PRESERVE also, friends, we know if you are discussing the SGLT2 inhibitor, we should be axis on the 3 axis. We know this molecule has some effect on the diuretic effect. So, one thing is very important with this kind of molecule with the SGLT2, this has caused diuresis, but this has effect especially on the interstitial fluid volume, not extracellular fluid volume. That is why with the diuresis this causes reduction in the intima medial thickness and flow the integrity of blood in the vascular endothelium, and that is why if you see the after using the all this SGLT2, there is some class effect, there is reduction in the biomarkers, anti-pro BNP, so and so, and there is reduction in filling pressure. So, effect of SGLT2 I will divide it into 3 categories. One, the preload effect of the SGLT2 inhibitor. We know this causes diuresis and reduce transmitral flow velocity and tissue Doppler velocity. So, there is a reduction in the E by E prime ratio and reduction in the filling pressure. On the same time, there is a data with the dapagliflozin that this causes reduction in the LA volume around 6 to 8 ml per millimeter square, and for the diagnosis of HFpEF, we know the important marker is increased L index volume, and on the same time there is a reduction in E by E prime around 2.5 to 3. So, if you combine this effect on the heart failure, there is a reduction in filling pressure. So, gradient from the LA to LV is reduced. If you are going to LV, there is a reduction in the concentric hypertrophy and there is a remodeling in the cavity. On the same time, if it is in the HFrEF, there is a improvement in the ejection fraction. And coming to afterload, there is a reduction in afterload also. So, just to summarize my talk, there is a better filling for blood from the LA to LV, better pumping and reduction in this afterload. So, we are getting net mechanical benefit and the electrophysiological benefit after using the SGLT2 inhibitor in heart failure. Thank you. This is all from my side.